Welcome to Chapter 8. You can see that it's entitled Joints, which is the name that your textbook uses, but you might also hear the term arthrology, basically just having to do with articulations or joints. And I have two examples here. This is your shoulder joint or your glenohumeral joint. Remember we had the glenoid cavity of the scapula, and this is the head of the humerus. And then this is your knee joint or your tibiofemoral joint. We'll talk more about these, but I thought you'd like to see a real anatomy example. Here we have just a basic definition of the word articulation. So it's the site where two or more bones meet. Also remember that ligaments hold bones together. You might also see the word disarticulated, and disarticulated would mean individual bones. So if you're holding just a femur or just a humerus, that's a disarticulated skeleton. If you are looking in lab at the skeleton that's wired together, standing skeleton, that would be an articulated skeleton. What do joints do for us? Well, they give the skeleton mobility and they hold the skeleton together. And then we're going to look at two classifications, one based on structural, so materials, and then functional, basically action, what it does. For structural classifications, we need to look at the material that binds the bones together. And there are three different types of structural classifications based on the binding material. So fibrous is the bones are held together by fibrous connective tissue. If it's a cartilaginous joint, the bones are held together by cartilage. If it's a synovial joint, it has a joint cavity, and this is going to have or produce synovial fluid. I will say this is the one that we probably think of the most often when we talk about joints. Synovial joints would be your knee, your hip, your shoulder. Functional classifications are based on the amount of movement at the joint. There are three functional classifications: synarthrosis, amphiarthrosis, and diarthrosis. This ending here is plural. You may also see the singular ending, which is SIS. And then if they're using this functional classification as an adjective, sometimes you see it listed as synarthrotic. You can see here that synarthrosis is immovable, amphi is slightly movable, and diarthrosis is freely movable. Let's look at our first type of structural joint, which is called a fibrous joint. The bones are held together by fibrous connective tissue. There's no joint cavity. Most of the bones are immovable, so we should be able to use the term synarthrotic, immovable. There are three types of fibrous joints. So there are sutures, syndesmoses, and gomphoses. Just in case I've lost you and you're confused, you might want to do an outline for the structural classifications. So remember, structure just has to do with building material. And we have fibrous, which was 1, cartilaginous, which was 2, and then synovial, which are 3. But I said there are 3 subtypes under fibrous. There are 2 subtypes under cartilaginous, and there are 6 subtypes underneath synovial. So if you want to keep an outline to keep all of this material straight, I highly suggest you do that, and I'll be showing you this outline as we fill it in. So here's our first example of a fibrous joint called a suture. These are interlocking joints that contain short connective tissue fibers. In middle age, they're going to ossify, and you might want to use the word fuse, that's fine. And once fused, they're immovable, and we call that synarthrotic. So go to this figure, and you can go back and name, this is your temporal, parietal, frontal, occipital. What's actually holding your parietal and your temporal together is fibrous connective tissue, and then eventually it's going to ossify or become bone, and then you would not be able to separate those two cranial bones. Second example, fibrous joint, is syndesmoses. These are bones connected by ligaments that are made up of fibrous tissue. On these, the movement varies. It depends on the length of the fibers. So if you have short fibers, like we have here at the distal tibiofibular joint, so that means at the farthest end of the tibia and the fibula, so this ligament here that's made up of fibrous connective tissue is immovable or synarthrotic. The second example, we're still talking about syndesmoses, are if you have long fiber types. So these are slightly movable or amphiarthrotic. And the best example is this interosseous connection between the radius and the ulna. So you can see here the interosseous membrane. So this would be considered slightly movable. The third type is called gomphoses. It's usually, we call it a peg and socket joint. The only example we see are in the teeth in the alveolar sockets. So here's the tooth. Here is the mandible. And you can see these tiny little fibrous connective tissue, sometimes called the periodontal ligament, and it's holding the tooth into the alveolar process of the mandible. What I like about this one is you can think gomphosis and your gums, right? So the next category we're going to look at are the cartilaginous joints. These are bones united by cartilage. There's still no joint cavity present. They say that they're not highly movable as a whole. There's a little bit of wiggle room when we come to the symphysis. So the two types are synchondroses and symphyses. We've already seen the pubic symphysis, right? So let's look at synchondrosis. This is hyaline cartilage, and it's usually in some sort of plate, and it unites the bones together. It is immovable, so we call it synarthrotic, and we've already seen epiphyseal plate. Remember that line that allows for growth, that hyaline cartilage that eventually is going to be ossified? And then a second example is between the first rib cartilage. Remember, this is that costal cartilage. And then this is the manubrium of the sternum. So the second example of a cartilaginous joint is symphysis, or pubic symphysis, that we've seen already. So remember, it's that fibrocartilage. Sometimes I said it was like a gel insole, right? It's strong, but it's also flexible. So we would call this slightly movable or amphiarthrotic. Remember, your spine has to be able to bend over and stand back up, and then as you're walking, remember that these coxal bones are moving in opposite directions as you swing your leg forward. So you have to have a little bit of movement at this particular joint. Just in case we're getting lost, here's an outline. We're filling it in. So the major types are fibrous, cartilaginous, and synovial. There are three subtypes: sutures, syndesmoses, gomphoses. And then there are two: cartilaginous, synchondrosis, and symphyses. And then we're going to see 6 different synovial joints. I would make sure for each of these you can list an example, and you can also talk about the immovability or slight movement, right? So far, list with example and with movement. Whether it is, so far we've only had synarthrotic and amphiarthrotic. So I'll give you a clue. When we get to synovial, this is when we're going to talk about diarthrotic. The third major category we're going to talk about are synovial joints. So you can see here that these are fluid-filled cavities. They're filled with synovial fluid. They're diarthrotic or freely movable. Think of most of our limb joints. There are going to be 6 general features that we're going to look at. We're going to talk about bursa and tendon sheaths. We're going to talk about the stability of the synovial joints. And then we're going to talk about the 6 different types of synovial joints. Here are the synovial joint features. 1, there's articular cartilage, which is hyaline cartilage that covers the ends. Remember, when 2 long bones, or 2 bones in general, come together, they're going to be covered in hyaline cartilage. Since it's the articulation site, we call it articular cartilage. We're going to see a joint cavity. Some people would call it a synovial cavity. It's going to be a fluid-filled space. You're going to see a capsule, an articular capsule. This is going to have connective tissue with the synovial membrane, which is going to produce the synovial fluid. So it's this slippery, sticky fluid. It's going to lubricate the articular cartilage. We're also going to see reinforcing ligaments. Remember, ligaments attach bone to bone, so they're going to be around the synovial joint and offering reinforcement. Then we're also going to see nerve and blood vessel supply. And what do these nerves do? They're going to signal pain or monitor position, sending messages back to your brain about the current condition of your joint. Here's a figure from your book so we can identify each of these structures. So the joint cavity contains synovial fluid. So this entire structure here, this is the joint cavity. It's filled with fluid, and remember that fluid was made by the synovial membrane. The synovial membrane is here in green. Then we have the articular cartilage, which binds the ends of each bone. And then we have a fibrous capsule here, and we have the ligament here. And both the fibrous capsule and the ligament are kind of supporting this joint cavity between the two bones. Another general feature of joint cavities are fat pads. And you can see this fat pad is kind of serving as a cushioning or a buffer between the synovial cavity, remember also called the joint cavity, and then the muscle and the bone. So it serves as a cushion for that joint. Another general feature is something called a meniscus. So anywhere that you need to have a better fit, that you're going to have lots of wear and tear, or a place where you would need to stabilize a joint, you'll have this fibrocartilage pad, and we call these meniscus or menisci. The next item that we're going to look at are these bursa or tendon sheaths. So bursa is one, bursae many, or bursae some people say. And these are basically bags or sacs of synovial fluid that act as a lubricating ball bearing. It's probably a little hard to think about when you're looking at these words on the slide, but when we get to the next picture, you'll see. It actually just helps with rotation and movement. So a bursa is a flattened sac, where a tendon sheath is an elongated sac. Here's a bursa. This is between the scapula and the humerus. And you can see it is a flattened sac. And what the bursa is going to do is it's going to roll, and it's going to lessen the friction between the scapula and the humerus, specifically at this ligament. You can see how the ligament sits directly on top of the bursa. So it kind of aids in movement. Here's another great example of the same bursa, but also looking at a tendon sheath. So in certain areas where you have lots of tendon attachment, you're going to actually not only have the flattened bursa sac, but you're going to have an elongated sac that you wrap around the tendons. So this is the tendon of one of your biceps brachii muscles. So the whole point of the bursa and the tendon sheaths are to aid in movement or rolling and reducing friction. So think of areas that you have many tendons running into a small compartmentalized area. So here, I wanted to show you, here are the ulnar bursa. You can see there's a radial bursa as well. Now we have lots of tendon sheaths. So if you count these are all tendons that have to run through the wrist. So there's 1, 2, 3, 4, 5, 6, 7, 8. So there's 8 tendons that run through this wrist area and extend all the way into your fingers so that you can curl your fingers. So the movement of your hand is actually directed by your forearm muscles. Remember, we also have in this region our carpals. So we've got 8 carpal bones as well. So there's many muscles and muscle tendons and many bones running through this area. So we're going to individually wrap all of these tendons with tendon sheaths, and we're also going to have bursa there as well to kind of reduce friction and allow for smoother movement. We have three factors that determine the stability of joints. One is the shape of the articular surfaces, the cartilage that's on the outside of each bone surface, the ligaments that hold bone to bone, and then we'll also look at the muscle tone and how the muscle tone helps stabilize the joint. Here are two figures that are going to help us explain the last slide. So we talked about the shape of the articular cartilage. I think I said structure in the last slide. But the articular, remember we have that hyaline articular cartilage, and you can see from this figure, if the bone shape or the articular cartilage was projecting farther out than it should be, the dotted line is kind of where it should be, and you can see in red that it's projecting farther posteriorly, you can see how that would impede joint movement and how it might cause issues with joint stability. For the ligament here, remember ligament is bone to bone, and we said the ligament helps prevent unwanted movement at the joint. Well, we can easily see how the ligament is providing stability by binding around the outer portion of the joint cavity, but it also, if it's tight enough or taut enough, it stops unwanted movement. It stops this joint cavity from shifting to the right or to the left. On this side, we have a muscle tone example. So you can see the muscle is bound to the bone via the tendon, and if this muscle is tight, you can see that the muscle would be pulled across the joint, also providing stability, keeping the joint in its location rather than shifting or moving. So here is a big picture question. Why are some people more flexible than others? Let's look at the factors that we talked about in stabilizing the joint cavity. So one, we could just say the shape of articular surfaces or structure. When you think of the shape of articular structure, you should be thinking about bone remodeling. If you think about bone remodeling, you should be thinking about osteoblasts, and then you should be thinking about stress, right? How is it that bone remodeling occurs lifelong? Because we're constantly putting stress on certain areas of our bones, and that's going to cause osteoblasts to build in that area. Two, ligaments. Ligaments are made up of connective tissue. What's inside, or what is connective tissue? What's a ligament made up of? In this, most connective tissues are made up of collagen. These are collagen fibers. But who made the collagen fibers? Do we remember we had fibroblasts? Fibroblasts are cells. Cells made the instruction code for collagen, because remember, cells make proteins, and that's what collagen is. It's a protein. And that instruction code came from DNA. Third, we have muscle tone. We don't have a lot of background information on muscle tone just yet, but we will once we go through the muscle chapters. But muscle tone can be controlled by the central nervous system, your brain. Remember, skeletal muscles are voluntary. Your brain decides their activity. You send a message to the muscle. It's not happening involuntarily. So central nervous system, but you can also make your muscles more toned by working out, right? So the more you work out, the more toned your muscles are. What about ligaments? We can stretch our ligaments, right? If we decided we were going to stretch on a daily basis, we could make our ligaments a little bit looser, right? And then the shape of the articular structure, if it's based on stress, what would happen if we started practicing to do this when we were 3 or 4 years old? As the shape of our bones were developing, we were applying stress and pressure on specific areas. So we could shape our articular structure, we could stretch our ligaments, and we could increase our muscle tone, and maybe, hopefully, we'd be able to assume this very flexible position. Next, we need to look at the movements allowed by synovial joints. We call this range of motion. Sometimes you'll see it abbreviated. So this is range of motion allowed by synovial joints. There's non-axial, so this is basically just slipping movements. There's uni for movement in one plane, bi for two, multi for many. And there are 3 general types of movements, but then we have subcategories under each of these. Here's the outline for these movements. So you'll see here all of the subcategories that we're going to talk about. There's a lot of new terminology in Chapter 8. I'd make sure I do outlines as much as possible. So again, we're going to talk about gliding, we're going to talk about angular movements, rotation, and then we have special movements. So you can see here we have special movements of the foot, we have special movements of the jaw, thumb, and then this here is the antebrachial region, which we should know as our forearm. Here's a great example of gliding. Remember they said this was kind of slipping movements only. This is at the intercarpal joints. So carpal tells you wrist bones, and inter is between them. So here are our carpal, and you can see that as you're moving your hand from side to side, some people say it's doing the little curtsy wave, that the bones here, the joints, are just slipping. They're gliding slightly back and forth. This is also a good example, though, to explain that there are several joint movements. So I don't want you to think that the hand only does gliding. We're talking about just the wrist right here. If we're talking about this area, let me clear this. If we're talking about where the ulna and the radius meet the carpals, so this is a different story, right? This is my radius, and this is my ulna. How do I know the difference? Pinky side is ulna side, thumb side is radius side. If we're talking about this joint where the carpals and the radius and the ulna meet, when we move to the next slide and you see flexion and extension and hyperextension, that's what's happening at this joint. So you have to be careful when you're analyzing joint movement that you're not looking at the wrong joint. The next topic we need to talk about is angular, or angular range of motion. We can increase or decrease the angle between 2 bones. So these are the angular movements that you need to know. Flexion decreases the angle of the joint. So if you have a 90 degree, you're bending your arm, then that would be flexion. Extension is when you go back to the normal position at 180 degrees. Hyperextension would be if you went beyond that 180 degrees. So any movement beyond the normal anatomical position. We'll look at abduction and adduction, and then we'll look at circumduction, which involves combining all of these: flexion, abduction, extension. Here's a great example of flexion and extension of the head. So extension is the normal anatomical position. Flexion, and that was this figure right here. So you can see this is the angle. Flexion, we decreased the angle, and hyperextension, we increased the angle. Moving down the body, we can look at flexion and extension at the trunk. So again, this is the normal anatomical position. If you decrease the angle, it's flexion. If you increase the angle, it's hyperextension. Some more examples of flexion and extension of the limbs. We're going to look at the shoulder joint, the elbow, the hip, and the knee. So here at the shoulder, if you are here, this is extension, right? Normal anatomical position. If you decrease the angle, that's flexion. If you increase the angle, that's hyperextension. At the elbow, so imagine this is at the elbow extension. We take our forearm and we bring it directly in front. That would be decreasing the angle, that would be flexion. You can see in this picture here, we cannot do hyperextension. Hyperextension would mean we could bring our forearm behind us at a right angle from our brachial region. So there is no hyperextension of the elbow, or there shouldn't be. It can happen with a lot of force, but we shouldn't have this normally. Now we're going to look at the hips if we bend at the waist. So again, this is extension, normal anatomical position. If we were to bend over, this would be flexion. We've decreased the angle. And if we are to bend backwards slightly, we have now increased the angle. That would be hyperextension. The last one to look at is at the knee. And we can see again, this is extension or normal anatomical position. Now we have decreased the angle, so this is flexion. But you can notice that there is no increasing the angle, so there is no hyperextension at the knee. Some more examples for you. Here's abduction and adduction. Sometimes people will say abduction and adduction. They'll purposely mispronounce them so that it's very clear as to what action or range of motion they're talking about. So abduction is moving away. Some people think of your abdominal muscles. You have to use your abdominal muscles if you're holding your arms up for an extended period of time. So think of it as arms away from the midline. And adduction or adduction, you're adding them back to midline. Circumduction is the combination of the two. In order to make circles, that's how most people think of it, as making circles. You have to do both abduction and adduction. Now we're on the third category. If you go back to your outline, we're talking about rotation, turning the bone around its own axis, either a medial or lateral rotation. So remember, medial is in the middle and lateral is on the side. Again, we have some figure examples of medial and lateral rotation. We're looking at the head. So you can turn your head laterally. That's lateral rotation. Or you can turn it back to the medial, which is the same as the normal anatomical position. You can think of that as extended if you'd like for now. You can also rotate at the hip. So you can turn your foot out, which would be lateral rotation, and then you can turn your foot back in, which would be medial rotation. Now we get to talk about special movements. So these are the special movements of the radius and the ulna, or our antebrachial, right, our forearm. And it's called supination and pronation. So supination, the palms are facing forward. The radius and the ulna are parallel. So this is your anatomical position. Pronation is when the palms face down or posteriorly and the radius rotates over the ulna. They cross. Here's the example of pronation and supination. You can see the radius and ulna are in parallel. Remember that in between here we had that fibrous joint, syndesmosis. It was called interosseous membrane. And we said it was slightly movable and we called it amphiarthrotic. You can see how this gives stability to the alignment, but also allow for some movement because now we have the radius crossing over the ulna when we're in pronation. The way that people remember this is they'll say to hold a bowl of soup, you would have to be in supination. For pronation, people have said, I now pronounce you man and wife. Could be wife and wife, husband and husband, doesn't matter, right? These words stem from prone and supine. So I wanted to mention that you could also have this in terms of the entire body. So prone would be laying face down, and supine would be laying face up. Now we're on to movements of the foot, and it's probably better to look at all of these in the figures. Here's a great figure for dorsiflexion and plantar flexion. We could look at it right away and say this is flexing the foot and this is pointing the foot. But we need to know the anatomical terms. Dorsiflexion, you're flexing the foot towards the shin. Sometimes people think of this as a heel strike if you do martial arts at all. And then plantar flexion, the toes are going away from the shin, and sometimes we would call this standing on our tippy toes. Next example of special movement of the foot is inversion. Remember, this is turning medially. So you're looking at the bottom of your foot. You're turning at the tarsal joint here, and you're looking at the underside of the foot. Eversion is if you're looking at the side of your foot, turning it laterally. We also have special movements of the mandible. We'll look at protraction, retraction, elevation, and depression. You can see here protraction is pushing your jaw forward, and retraction is bringing it back in. Most of us can figure out elevation and depression. So elevation is lift, depression is bring down. What we should notice about these special movements of the mandible is that you need all four to bite and chew food. So think about taking a bite of an apple. You would have to, one, depress the mandible, then you would have to elevate the mandible to take the bite. So bite are these two, elevation and depression. To chew, you would have to do protraction and retraction. So all four special movements of the mandible are necessary in order to bite and chew food, which we need food because why? We need to get glucose because we have to make what? ATP. The last special movement is of the thumb. So opposition is when the thumb touches the tips of other fingers. So this right here is opposition. When the thumb goes back, you might hear people call it reposition. It goes back to its normal anatomical position. And this is great for grasping, right? To be able to hold a pen. Try taping your thumb to the palm of your hand, and then try to take notes, or try to button a button, or zip a zipper. So having opposable thumbs is a great feature. Big question again, big picture question. So name the joint movements involved in holding a pen to write notes. The reason I'm asking this is we use these joint movements all the time, we just didn't know what they were called. So remember, if your hand is in anatomical position, your fingers are straight. So you're going to have to flex your first finger or phalange, right? You have to bend your finger down to touch the top of the pen. Right away, you should also get opposition. We have to bring our thumb to the first finger. Now we're holding the pen. The last thing that we probably don't think about is that you have to adduct the other fingers. We don't just hold our first finger and our thumb together in opposition and leave our other fingers straight or in anatomical position. We usually bring them down and wrap them underneath the pen. So you're doing flexion, opposition, and adduction just for one movement, which is to hold a pen. Now we get to actually look at the types of synovial joints. So before we were just looking at the range of motion or movement in a synovial joint. These are the 6 types based on the articular surfaces and their movement. So we classify them as plane, hinge, pivot, condylar, saddle, and ball and socket. This is the one that we're the most familiar with. These are the shoulder joints, the hip joint. But remember, all of these are diarthrotic. Okay, our first example is a plane joint. You can see that they have flat articular surfaces. They do these short gliding movements, and we use the term non-axial. So even though these are all diarthrotic, there is some limit to their movement, and we'll start using these terms: non-axial, uniaxial, biaxial, and multiaxial. So basically we're just doing a gliding motion back and forth. The best example of this is at the intercarpal joints, so right here between 2 carpals. Second example we have is a hinge joint. This is motion along a single plane. So if you see single, you should think uniaxial movement. Flexion and extension only. So what does that mean? That means no hyperextension. Best example of a hinge joint is your elbow. Some people think of it as a one-way door, right? You can only do flexion and extension. You can't do hyperextension. Remember, this is our trochlea, the capitulum. This is the trochlear notch. On the back side, we have the olecranon process. And if you look at that joint, you know that there's no hyperextension of the elbow. Third example of a synovial joint type is a pivot joint. This is when you have a rounded end of bone that conforms to another bone. So here's the ulna, here's the radius, you see the ligament. And remember, this is uniaxial. We can go back to supination, which is anatomical position, and you could go to pronation. That's it. It's only one movement. Palm up, palm down. Fourth type we have to look at are condylar joints. So the articular surfaces are oval, and it allows for angular movements. So that was our flexion, extension, hyperextension, abduction, adduction, circumduction. You can see here the metacarpals, here are the phalanges. So we're looking at this joint. A great example of a condylar joint is the metacarpophalangeal joint, which is basically your knuckles. Long word, right? I love joint names because they take the two bone names, they remove some of it, and they put an O in between it. So you can usually figure out joints pretty quickly. The only thing I want to mention is that even though it's saying it permits all angular movements, it's not the same. You'll see here it's biaxial. When we get to the very last ball and socket joint, that one is multiaxial. So there's still a few areas. You can't completely circumduct your metacarpophalangeal joint. You'll feel like a little hiccup when or a little pop when you're trying to do the circumduction. So it's not quite as smooth. So we still call it biaxial. You can move your finger up and down and side to side, but you really can't make a completely smooth circumduction. Fifth type of joint, saddle. We're still talking about synovial joints, right? We have a little bit more movement here than we had in the condylar. We have concave and a convex area, so you can see them here. The best example is a carpometacarpal joint. So you should be able to figure this out. Carpal means wrist. Metacarpal are bones of the hand. So we're looking here at the trapezium, this carpal bone, and we're looking at your first metacarpal. Trapezium is always under the thumb. I like the endings. Okay, so again, this is biaxial movement. So think about your thumb. You can do opposition and reposition. You can do abduction and adduction, but you can't do a complete circular free movement with your thumb. So the sixth and final synovial joint type is the ball and socket. This is the most freely movable synovial joint. It's the only one that's multi-axial. So because of the ball and socket, like the scapula, and we should know this is the glenoid cavity. So looking at this joint and moving your arm, you basically have a free range of motion. You can completely circumduct the arm. So this is the only multi-axial type of synovial joint. Oh no, back to the outline, right? I just want to make sure we understand what we need to know for each of these joint types. So you need to know the major categories. You need to be able to tell me about the subcategories. You need to be able to give me an example of each. And you need to tell me about movement. So you need to use those synarthrotic, amphiarthrotic for all of these. You have to know that these are diarthrotic. You have to give me an example of each of these. And then you have to tell me something about the axial movement. So remember we had non, uni, bi, and multi. So make sure that you can categorize all of these, give me examples, and tell me about movement. So this last section, I just want to go through some of the synovial joints and look at how complex they are. So we're going to look at the knee joint, the shoulder, the elbow, the hip, and the jaw. So the knee joint's the first one that we're going to look at. I love the names of joints because they tell you exactly what they're talking about. This is where the tibia and the femur come together, or the tibiofemoral joint. It's the largest, it's the most complex. There's 3 joints surrounded by a single joint cavity. We have 12 associated bursa. We also have menisci. So let's take a look at that. Here's a sagittal section of the right knee. You can see the bursa, several of them. You can also see the meniscus. It would be here, but they cut it. There's also another one on the inside or medial side, but we can't see that with this section. And then what I like to point out is the PCL and the ACL. So you can see this crossover of ligaments, PCL and ACL, and these help keep the femur and the tibia in articulation. These are what get damaged during sports. So these ligaments are really good at the bending motion, but they're not good at side impact. So when you have side impact is when they usually tear. So I wanted to show you an anterior view of the right knee with the muscles attached so that you can see this adds another layer of complication. It's both good and bad. Remember we said we have muscle tone and we have ligaments, and these help with stability of the joint. So we can see the ligament here, we can see the muscle here as the tendon is attaching the bone. So that's all great for stability, but imagine if you damage any of these areas. So basically we have very complicated structure, many different players, if you will, ligaments and tendons, all of these bursa, all in a very small confined area. So damage to one could actually affect all of the joint. Another complex joint to look at is the shoulder joint. We would call this the glenohumeral joint. Remember, this is where the glenoid cavity of the scapula articulates with the head of the humerus. So by the test, you should be able to list the feature and the bone as they come together at an articulation site. Again, you can see how complex this is. There's tendon sheaths, there's tendons, there's bursa. Again, another complex joint. Another complicated joint, the elbow joint. This is the humeral radial and humeral ulnar. You can see the bursa, you can see the tendons, you can see the fat pad. So another complex joint. Next joint to look at is the hip joint. You can see acetabulofemoral. Again, we just move the ending and put in an O. So this is where the acetabulum of the coxal bone, or the os coxa, joins the femur. You can see ligaments holding the joint together. You can see the synovial cavity. One of the things to notice is that there is a ligament that holds the femur into its socket. So this is a pretty strong joint. You can see that the head of the femur fits very deeply into the acetabulum pocket, and we also have this internal ligament that's going to hold the head of the femur to the acetabulum feature on the os coxa. What usually causes this joint to become unstable later in life is osteoporosis. So as these bones weaken or become more porous, that's when you have dislocation of the hip or you have an actual break in these areas. Last one is the jaw joint, or the temporomandibular joint. So remember, this is where your temporal bone and your mandible come together. So here's an enlarged view of your temporomandibular joint. Hopefully by now you may have recognized TMJ. So what's interesting is some people will say, I have TMJ. Well, everyone has TMJ. Everyone has a temporomandibular joint. They may have inflammation in their TMJ, they may have dislocation of their TMJ, but we all have a temporal mandibular joint. You can see the mandibular fossa here. Hopefully we remember where this is. This is in our temporal bone, a feature of our temporal bone. This is the mandibular condyle of our mandible. So this is your TMJ. I've included the tables from the book. Don't panic. You do not have to know all of these. This is kind of for your information. If you want to look through all of the joint names, the bones that they articulate to, what type of structure, and then the functional movements, you can look through the table in the book. Basically, just focus on the ones that we discussed or we used as an example. So of course, with the complexity of joints, we can have disorders and injuries. We've talked about a few, but here are a few more. Cartilage tears. Remember, this is avascular tissue, connective tissue, right? Means no blood supply, which means that it can rarely repair itself. You usually have to have surgery. Sprains, the P is talking about ligaments that are stretched or torn. And I say that because people use the word strain interchangeably, but the T in strain is when you have a tendon that's stretched or torn. So they don't mean the same thing. You also can have dislocations. This is when the bone is forced out of alignment. We can also have inflammatory or degenerative conditions of a joint. These four we're going to talk about on slides coming up in just a second. Here we have bursitis and tendinitis. The itis means inflammation, and then it's either of a bursa or a tendon sheath. And remember, if these synovial fluid-filled sacs are there to help with the range of motion and the ease of movement of the joint. If they're inflamed, they're going to impede that movement. So we can look at the general term arthritis. So the itis is going to say something about inflammatory. We have acute forms. Acute means now, current, short term. Chronic means ongoing. So you can have acute forms of arthritis. Usually it's some sort of inflammation. We can treat the bacteria with antibiotics and kill them. There are 100 different types. The chronic forms are the ones that we'll look at the next couple of slides. You can have osteoarthritis, so it's going to have something to do with bone, right? We can have rheumatoid arthritis, and we can have gouty arthritis. So we will look at these on the next slides. So the first type of chronic arthritis we're going to look at is called osteoarthritis. It's very common. It's irreversible. We can't really fix it unless we're going to replace the joint itself. So we call this wear and tear arthritis, and you can see it's the breakdown of articular cartilage. So you see the articular cartilage breaks down, and then you end up with exposed bone. You can see in this second type, this rheumatoid arthritis, this is chronic, ongoing. It's inflammatory, and it's an autoimmune disease. So basically, your immune system is attacking your joints. And let me change colors here so you can see. So remember, this is my metacarpophalangeal joint, my knuckle, and you can see that they've kind of been shifted. So usually arises between 40 and 50, can occur at any age though, and women are 3 times more likely than men, and the cause is unknown. Gouty arthritis is another type of chronic inflammation. It's the deposit of these uric acid crystals in the joints. It's more common in men, and usually we see the accumulation of these crystals at the base of the great toe. So we think that it has something to do with the fact that the crystals are more dense and they kind of drop to the lowest point of gravity, which would be in the joint of the great toe. So think about crystals, sharp-edged crystals, poking you in your synovial membrane or in your articular cartilage. So any sort of movement is going to cause you great pain. The last disease we'll talk about or disorder is Lyme disease. And Lyme disease can lead to joint pain and arthritis. It's a bacteria that's transmitted by tick bites. This is really fascinating, some of the research and things that have come out about Lyme disease that you can research if you would like to in your free time. Developmental aspects of joints. By about week 8 in the embryo, we can see synovial joints. Obviously, as we age, everything gets worse, right? And the ligaments and the tendons are going to shorten and weaken. The key seems to be doing full range motion exercises. So my advice, take it or leave it, is start doing yoga. Please look inside Blackboard and you should see range of motion questions. So these kind of just give you an idea of test questions that I could ask about range of motion. These seem to throw us a little bit. So all of these are hinge joints except for, so which one is not a hinge joint? And remember, a hinge is, you can only bend in one direction, right? Our hinge joint example, we thought of our elbow. So your femur and your tibia, you can only flex and extend. So that is a hinge. Phalanges. Be careful. This is not between your metacarpals and your phalanges. This is not your metacarpal phalangeal joint. Between your phalanges, they're talking about the distal, middle, and proximal phalanx. So just at the tip of your finger, this is still only flex and extend. So this is a hinge. The humerus, radius, and ulna. This is your elbow. This was our great example of a hinge joint. So this is hinge. Your atlas and your axis. Well, it's the only answer left that's not, so it must be the correct answer. But also think about what type of joint it is. So remember, we had our axis, which has that dens that sticks up, and then our atlas comes around. This is a pivot point. So the atlas and the axis is actually a pivot joint. So you have to be able to think about these articulations and think of the way in which they move. So please look at the range of motion questions. There will be a few of these on your exam. The last thing to look at are these articulation sites. You can also say these are joints, but I want you to be able to explain the joint. So this is our TMJ, right, our temporomandibular joint, but can you also break it down into the bones and the bone features? So the mandibular condyles of the mandible articulate with the mandibular fossa of the temporal bone. So inside Blackboard again, there's an articulation worksheet and it goes through several of these. Here's the capitulum of the humerus articulates with the head of the radius. The trochlea of the humerus articulates with the trochlear notch of the ulna. So there's several of these to look at. Again, there'll be a few questions on the test about articulations.